A 30-year-old patient presented with headaches and suspected sinusitis. I am showing you an occipitomental plane radiograph of the sinuses. Describe the findings.
Okay, assessing the provided imaging, the occipitomental radiograph shows a large, radio-opaque calcified lesion in the right frontal sinus. The lesion has very well-defined smooth margins and demonstrates a slightly lower density central zone. No air fluid levels or mucosal thickening are seen within the rest of the sinus. Importantly, there is no evidence of local aggressive bony destruction or cortical expansion on this projection.
I'm showing you two coronal CT reconstruction images of the sinuses. What do they demonstrate?
The first coronal CT reconstruction confirms a dense, bony density lesion arising within the right frontal sinus, matching the radiograph. The second coronal CT reconstruction from a different patient demonstrates a left ethmoid sinus, osteoma. This left ethmoid lesion is causing pressure erosion of the lamina papyracea and extending directly into the medial orbit. There is associated inflammatory mucosal thickening within the left maxillary and ethmoid sinuses, likely secondary to ductal obstruction.
What is the diagnosis? Discuss the pathology, typical locations, and systemic syndromes associated with this lesion.
The diagnosis is an ivory osteoma of the paranasal sinuses. Osteomas are benign, slow-growing bone tumors composed of mature, compact, or cancellous membranous bone. They are most commonly found in the paranasal sinuses, particularly the frontal and ethmoid sinuses, as well as the calvarium and mandible. Crucially, the presence of multiple osteomas should raise immediate suspicion for Gardner's syndrome. Gardner's syndrome is an autosomal dominant variant of familial adenomatous polyposis, characterized by multiple osteomas, soft tissue tumors, and premalignant colonic polyposis.
What are the potential clinical presentations and complications of paranasal sinus osteomas?
In that case, while most osteomas are asymptomatic incidental findings, they can cause symptoms if they obstruct sinus drainage pathways. This obstruction can lead to chronic sinusitis, mucocele formation, and localized headaches. Complications include pressure erosion of the sinus walls, leading to intraorbital extension or intracranial complications like pneumocephalus or CSF rhinorrhea. Intraorbital extension can present clinically with progressive proptosis, diplopia, and restricted ocular movements.
How would you manage this patient as a radiologist?
Well, as a radiologist, if this is an isolated, asymptomatic incidental osteoma, I would recommend no further imaging or treatment. If the patient has persistent headaches or symptoms of sinusitis, I would recommend a non-contrast paranasal sinus CT to evaluate sinus patency and rule out complications. If multiple osteomas are identified, I would immediately recommend a clinical workup for Gardner syndrome, including a family history evaluation and referral for colonoscopy. For symptomatic or expanding osteomas extending to the orbit or anterior cranial fossa, I would recommend referral to ENT for surgical resection.